Good afternoon, everybody. Welcome to a special session this afternoon called Men, MS, Intimacy and Sexuality. You'll have to excuse me, I've got a bit of a cold, but I will do my best to, lucky you can't see me, and I'm not like that journey anyway. But so what we've done is done a video with Dr. Aaron Boster, which I'll introduce shortly. Aaron is in America, so we couldn't really do a live webinar with him. But I'll be available at the end of the webinar to answer. We've had some questions come in, and I'll be able to answer any additional questions as well too. My name's Jodi Haartsen. I'm an MS consultant, MS practitioner, and also executive manager of Client and Wellbeing at MS Plus, and hopefully we'll be joined by Silas as well too. In the spirit of reconciliation, MS Plus acknowledges the traditional custodians of the country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal Torres Strait Islanders peoples today. So Dr. Aaron Boster is a well-known, almost celebrity in the MS space. He is a very influential MS neurologist, and certainly in terms of his academic influence, but also his social media presence. Aaron is really passionate about, I've had the good fortune of meeting him at a conference, a global conference, and he's very passionate about translating medical information to people. So you can read here, he's from Cincinnati, University of Cincinnati College, and he's got his own MS centre. Silas is a person living with MS, and hopefully he'll join us later on today.
I'm here.
Oh, hi Silas, yay, you're here. Good, that's great. We'll see you after the video.
This is a trigger warning. The following webinar recording features American neurologist Dr. Aaron Boster, who discusses men's sexual health, intimacy and other topics, dealing with the treatment and management of men's sexual function.
Dr. Boster, let's get back to basic and talk about sex. Why do we need to talk about sex and men's health in MS? What are some of the key issues?
This is a very important and underappreciated topic. So I'll just start by saying thank you for creating a forum where we can have this conversation. Very interestingly, in the MS space, men are a minority. And when we gather in groups and support groups and other opportunities to come together as a community, it's oftentimes 3-to-1 women to men in the room. And this is very relevant because oftentimes MS can affect the down theres, bowel, bladder, and bedroom. And you might not be comfortable discussing such personal things in a group, and you most certainly might not be comfortable sharing them in a mixed group of men and women. And so what I have found over doing MS care for 20 years now is that many men feel marginalized and they have difficulties with the down theres, but they don't feel like they have an opportunity to talk about it, or they're nervous to talk about it. So thank you very much for creating this opportunity, because it is so important. The reality is many symptoms in MS are invisible, and that doesn't make them any less real. On the contrary, they're very, very real. They're just invisible to the naked observer. We've all heard the not funny jokes. Oh, honey, you don't look sick. Well, you don't look ill-informed, that whole discussion. But I really think that when you think about invisible symptoms, there are two categories that really destroy the quality of one's life: the up theres and the down theres. And today we're going to talk about the down theres, bowel, bladder, and sexual function. And so it's not uncommon that a gentleman with MS can experience sexual dysfunction at some point in time. And I, as a clinician, spend a lot of time making families understand that I'm very comfortable talking about sex, because I don't know if they're going to have a problem. So I want to create an environment where they can say, hey, I got something going on. I think if someone is courageous enough to say, hey, I have a problem in the bedroom, I think we should really honor that. Like, we have to be very respectful of that. And we want to make darn sure that we continue to foster an environment where they feel safe sharing, because otherwise a guy will clam up and then you'll never hear from him again. And as a result, his quality of life will plummet. And so I then turn my attention to trying to make things functionally better. I divide my thoughts in three twice. So when I think about types of sexual dysfunction in MS, I immediately try to think about primary, secondary, and tertiary sexual dysfunction. So if I can just provide some like working definitions.
Yeah.
Primary sexual dysfunction, as I think about it, is when the neurological circuitry of sex has been damaged by MS. So the neural pathways involved in sex, so arousal for a gentleman, obtaining an erection, maintaining an erection, and then triggering the parasympathetic system to ejaculate, to have an orgasm. Those are driven by the nervous system, and unfortunately, with brain and spinal cord involvement in MS, you can have primary sexual dysfunction. And that's relevant, and I'll talk about later how we treat that. Secondary sexual dysfunction is not when the circuitry of sex has been damaged, resulting in difficulty with erection or ejaculation. It's when symptoms of MS interfere with sexy time. So for example, if you're getting your groove on and then your leg goes into an extensor spasm, you're not having sex anymore. You're rolling around on the floor screaming in pain, and your partner is like hovering over you, not sure what to do. And that, you know, the evening just changed. If you are incontinent of stool, that's not very sexy. If you have neuropathic pain when the inside of your leg is touched, that can really destroy sexy. And so secondary sexual dysfunction is very important to talk about because it's not self-evident that that's why someone's having problems with X or Y. Tertiary sexual dysfunction is a psychological phenomenon where the human being doesn't feel sexy. They feel sick. They feel like they feel ill, or like an invalid, or whatever word you want to use to say. They just don't feel like maybe they deserve to be having sex or they should be having sex. And in my experience with gentlemen with MS, it's typically a little bit of all three. Sometimes it's more one than the other. And I think thinking about it in that framework is very, very helpful. So I have a tendency to be a little bit long-winded, so I'll send the mic back to you.
That's fine. I think that certainly in my experience as an MS nurse too, you mentioned just creating that safe space, and that safety of being able to openly talk about it, I think, is really one of the keys to that discussion for so many men that I saw in clinic. We could open that discussion, but I could feel the awkwardness when we started talking about it. And then but acknowledging out loud that this is a safe space. And I would often ask men in my nursing practice if they felt more comfortable talking to a male neurologist, and many did. And women feel more comfortable talking to women. And so I often then would say, hey, we've got a male neurologist here, and if you're comfortable and you feel safer and you feel more open, and there was always this sense of, oh, I'm so relieved. And so that I've got it, not only that I've got a safe space to talk about it, we say, has MS impacted your sexual function? And the other thing that I also really resonated with when you mentioned it was that sense of that how MS impacts your sense of identity. And as a male and female and male, but in a male and sexuality, that's really...
We love our erections. I mean, we are big fans. And if we lose the quality of our erection, it doesn't sit well. I mean, it bothers us. You're spot on. I agree.
How is your routine practice to ask about it in clinic?
So when I do a initial consultation, I go through a review of symptoms, not systems, but symptoms, MS symptoms. And I finish up with, I say, I now need to talk about the down there's, bowel, bladder, and bedroom. Why? Because they're all in the same location in the brain and spinal cord. And I start by asking about bladder, accidents, near accidents, difficulty emptying, frequent urinary tract infections. Okay. Then we talk about bowel, accidents, near accidents, constipation, pain with moving your bowels. Say, okay. Now the sexual function's in the same location. So I want to know about difficulty with arousal, becoming excited, obtaining, maintaining an erection, adequate for penetration if that's the goal, and then ejaculation. And then I'm quiet. And it's been my experience when I present it like that, they kind of realize I'm not joking around, and I really want to know the answer, and they're like, yeah, I can't get an erection, or whatever the case may be. That sets the stage And at every follow-up visit, I ask them about the invisible symptoms of the up there's, energy, mood, thinking, and memory, and the down there's, bowel, bladder, and sexual function. And I make a lot of comments and jokes about sex being important on purpose, because I want to convey to the family in the room that that is something that I am comfortable talking about. Now, I have many team members, and I have team members that are women, but I'll be honest with you. Whereas I appreciate your comment that sometimes someone's more comfortable with someone of the same gender, I don't know how terribly important that is at the end of the day. I think the relationship is the key. And if that person feels comfortable with you, I would encourage you to move head on. You know, because I think that sometimes, you know, you don't want to pass off that person, you know, and you feel a sense of engagement. So that's typically how I approach it. Now, we also capture the patient's voice through patient-reported outcome measures. Before they enter clinic, they're handed an iPad and they click little buttons. And the reason I bring that up to you is not every guy is going to stand up and say, I can't ejaculate. You know, that's maybe embarrassing or something. And so being able to just to put it down on the sheet, on the patient-reported outcome measure is another way. Another thing that can be very helpful is to ask people to write down the things that are bothering them, because then they don't have to speak it out loud and they can literally just show it to you. So these are all different tools that I use in the clinic setting to try to help create a space of comfort and to really drill down, tell me what's going on in the bedroom.
Yeah, I think combining it with bladder, bowel and sexual dysfunction sort of as well kind of medicalizes it, which can also create that sense of safety in the discussion as well too.
Yeah, and you say, okay, well, you know, yeah, I'm having erectile dysfunction, but I'm so glad to hear that my bowel and bladder is not a problem. Apparently it could be, you know, you can frame it that way.
Yeah. So how do you go about treatment? What are the sort of the main pillars of how you go about treatment for, I understand there are many diverse problems, but what's sort of your overall approach?
So I think it's a fool who thinks that you fix male sexual dysfunction with Viagra, right? So I think it's very short-sighted to just give a pill. Now, let's be honest, these medicines are very transformative, they can help, but that's not the crux of it. So I think the first thing that we have to do is we have to normalize it, which is what you and I have been talking about. And then we have to drill down on where the problem is. So if we're dealing with tertiary sexual dysfunction, which is the psychology of not feeling sexy, and if that is, let's say, interfering with a primary relationship, a relationship with a spouse or a significant other. So the best approach might be to cultivate communication and to cultivate intimacy without intercourse, and possibly to get a therapist to talk with them. It doesn't have to be a sex therapist, because when a couple starts talking, they start to discover that, oh wait, I can sit next to you and hold your hand and I can feel intimate. I can kiss you and feel intimate. We don't have to do the deed, or, you know, you can start to approach it that way. That is a very, very different path that we would take dealing with tertiary sexual dysfunction than if the primary problem were spasms during intercourse. If the primary problem is secondary sexual dysfunction, we need to drill down as to which of those problems, and I'll use spasticity as an example, and I'll share a favorite story of mine. There's a gentleman I take care of, primary progressive MS, a wonderful gentleman, very, very nice wife. Although she tattles on him whenever he does anything he's not supposed to. Like if he smokes, she calls me and reports, which I love. And he has an intrathecal baclofen pump for severe spasticity. And he has trouble with spasms during intercourse, and they're so painful that he has to stop. And so his primary care doctor gave him Valium to stop the spasms, and it stopped the spasms, and it made him fall asleep during intercourse, which his wife was very upset about, so that just didn't work. But in talking to him, I realized that when he has an MRI, I use the pump and I click a button, and I give him a bolus of baclofen through his pump. And that makes his legs nice and loose, and he's able to have the MRI. He's laying down having the MRI. So I got him a little gizmo, which is called a PTM, that he takes home. And before intercourse, he hits the button, and it makes his pump bolus him, and his legs are nice and loose. And then he can lay down, and he can have outstanding intercourse. And so I view that as like a massive success. This is an example of improving intercourse by managing secondary sexual dysfunction. I'll give you one other example. And it's the only time in my career I've seen this, but I have a patient, a dear patient of mine, and he has heat-induced erectile dysfunction, which is very problematic because if you're doing it right, you might heat up your body a bit, and then he would lose his ability to maintain his erection. Ampira, 4-aminopyridine, or fampyridine, which is intended to help with heat sensitivity, allows him to, quote, be 18 again, end quote. That's a quote from his wife. So my point here in bringing this up is if the problem is secondary sexual dysfunction, we're attacking it rather differently than tertiary sexual dysfunction. If we're dealing with...
Actually, I've heard of that. I have had another patient who had the same response to 4-aminopyridine as well too. Very happy to.
I've been asking for like 10 years, and I'm delighted. That's my second time. Okay, good.
Yes, absolutely.
People think I'm nuts because I keep saying any improvement in the bedroom, and they keep saying, what? It's a walking pill. I said, you don't have to just walk, but that's awesome. Now, I want to turn our attention to primary sexual dysfunction, which is arguably one of the most common presentations of sexual dysfunction in men with MS. And this is where lesions of the spinal cord predominantly interfere. Now, what I mean by this is right now, as I speak to you, I'm using Aaron's indoor voice. I'm not yelling. Why? Because there's no excessive noise in your office or mine, and my mic works and your speakers work, so we can just talk at a normal, there's no interference. Now, if the rest of your team shuffled into your office and the rest of my team shuffled into my office and everybody was talking, the ambient noise would be so difficult that if I used my normal voice, you wouldn't be able to hear me. And so I would have to start screaming at the top of my lungs so that I could overcome the interference to get to your ear. So the exact same problem occurs in primary sexual dysfunction. When you stimulate the down theres, it sends a message up the spinal cord to a place in the brain to say, hey, woohoo! And then the brain says, oh, okay. And then it sends a message back down for erection and ejaculation, or the female equivalent, lubrication and orgasm, right? So sometimes when there's a lesion in the spinal cord, the message dies along the way. So here you are desperately trying to stimulate the down theres, but the message isn't getting to the brain, so the brain doesn't know what it's supposed to do. So this is where we introduce what I call overdrive stimulation, all right? And I specifically reference a Hitachi magic wand. So in the United States, you can use Amazon Prime and get a Hitachi magic wand for 50, 60 bucks. I know this because I own two. And these are hardcore plug-in-the-wall back massagers, right? And I encourage my patients to get a water-based lubricant and one of these Hitachi magic wands and turn it on. And we need DC power. I mean, I want, not a double D battery kind of thing. And then I want them to apply it to the shaft of the penis, the glans penis, under the testicles and the perineum, somewhere where it feels good. And it will provide overdrive stimulation far above and beyond gentle touch or what have you. Oftentimes, it's adequate for maintaining an erection. And you can use it when masturbating. You can use it between you and your partner. Literally, you can hold it between the two of you. I tell the patient, I want you to think of it as like a tag team. It's like your buddy that's helping you. And if it doesn't work, then put it back in the box and put a bow around it and give it to your wife. And so that's one way that we might overcome primary sexual dysfunction. Going back to my very earlier comment about a pill for that ill. So medicines like sildenafil, these medicines, Viagra, Silas is another trade name here, they're used very commonly and they can help gentlemen, but they typically don't take care of all the different problems. And so I think if you're identifying a problem with sex, it's not wrong to try those pills. I use them in many, many patients. Another thing, before we get off the topic of primary sexual dysfunction, is the discussion of testosterone. So testosterone is the male sex hormone, and testosterone levels are very important in the setting of multiple sclerosis for men. It turns out that low levels of testosterone in men with MS drive MS faster, which is terrifying. They can actually cause cognitive impairment, which is almost like a bad joke, except it's actually true. And of course, it can interrupt the bedroom. And so one of the things that I want to do when working someone up, along with all the other stuff I've talked about, is I always check two early morning testosterone levels. And if those levels are low, boy, we're going to give them exogenous testosterone to get those levels back up, both to help slow down the MS and to help with cognition. And there's a side effect of fantastic performance in the bedroom or the bathroom or the gym or wherever it is you get to have sex.
Yeah, excellent. Yeah, we don't routinely test in Australia for testosterone, but it is certainly becoming far more common that that's being considered, and I think that research continues to grow with the relationship between testosterone and MS for sure.
I agree. I lament that I didn't check routinely in the past, and now that I have adopted a plan where I check all gentlemen twice a year, I am shocked at how low many gentlemen's testosterone is. And so I feel in the same fashion where I'm a big believer in supplementing vitamin D, I'm a big believer in supplementing vitamin T amongst gentlemen with low T.
All part of that, like you said, that big, it's not just Cialis or Viagra, it's all
No.
the way that it's treated.
This is complex stuff, and it requires complex or multi-pronged approaches to beat it, but we can beat it. If I go back to this primary sexual dysfunction, if a pill doesn't help, there is a earlier technology. There's a shot in the side of the penis, which makes most men go like this, But the thing is, it's extremely effective. And some gentlemen, for various reasons, can't tolerate the pills, and so we use these injections, and it works very, very well. At the risk of sounding like Austin Powers, a suction pump can be very, very helpful. And I have some patients who have ultimately gotten a penile prosthesis. So that is an implanted device which makes them 18 again. And I currently have several gentlemen in my practice that because their erectile dysfunction was so severe, they opted to have this. And I can share with you that every single one of them can't stop talking about it. So
they're very happy with the outcome.
Yeah,
and no wonder it's an important part of our life.
But beyond happy. I mean, I want to stress, like, we're talking like high fives and celebrating type of behavior. So, what I would say to a gentleman is, you have to tell me how bad you want to be able to have sex, because I can get you there. It's just a matter of how serious are you.
and where do you want to go with that? Yeah, I've often found that discussing even simple things like positioning, opening the discussion about different positions and different, even that can really change. People just have this sort of expectation that everything's going to be the same. And talking about that different discussion about, have you thought about changing your positions? And
I'm so glad you brought that up. And I 100% agree with you. Many of us eat the same way every meal. We hold the fork in the same hand. We hold the spoon in the same hand. We tend to eat this part of the meal before this part of the meal. We tend to take a shower in the same pattern. I wash my chest, then my back. I wash my left leg, then my right leg. And I always do it the same way, what have you. It turns out that partners will oftentimes fall into sexual patterns. Kissing, oral sex, missionary position, go to sleep. Some type of pattern. And it also goes beyond that. So for example, they may only have sex at night because the kids are awake until nighttime and they're at work until nighttime. So nighttime's the only time they see each other. So you fall into these patterns. And I think what you're pointing out is critically important. You have to analyze the patterns. For example, my patients tend to have the least amount of energy before bed. They tend to have the most amount of energy when they wake up. So waiting until 10 p.m. to have sex is sometimes recipe for frustration, whereas they are ready to rock and roll at 8 in the morning. So you go back to your comment about positions. If you think about, let's use, I brought up the missionary position where the gentleman is on top of the gal and they're facing each other. I think Shakespeare said the beast with two backs. And that's a position that requires a lot of core balance and strength and upper body strength for both partners. And it might not be feasible to maintain that. And if you aren't creative, then it can lead to, I don't want to do this anymore. So the solution is something that I find to be terribly sexy, but it's uncomfortable if you're not used to it. It's talking. See, I'm of the opinion, if you can get naked and put a part of your body inside of another human, you better be able to talk to that human and have a conversation with them, right? And I think that's true for all partners. And so the conversation that I want them to have is, hey, I do really well with doggy style, but I can't balance if you're on top, or, this is the kind of conversation. And then you can say, I've always wanted to try the flying Walinda, but I don't know if I can hold that position. Sometimes my bladder bothers me and I might need to, in other words, you can game out what you are interested in, not interested in, things that have worked, things that haven't worked. And I think what people who are listening may find if they try this is the sex is better because the intimacy is improved and the communication is improved and there's not a lot of guesswork. And so time and time again, now I want to kick it up a notch and I want to recommend a assist device. So you and I are currently using assist devices. So I'm blind as a bat. I can't find my glasses without my glasses. It's a real problem, actually. So this is an assist device. And sometimes people who have an unsteady walk, they may use a stick. That's an assist device. So that way, because they're smart, they don't want to fall. So earlier today, I talked about an assist device, the Hitachi Magic Wand, the plug-in-the-wall vibrator. The second best assist device is a sex swing. And I think every adult should have a sex swing, particularly every adult with MS. So what we're talking about is putting an eye bolt discreetly in the beam of your bedroom. And when sexy time comes, there's a cloth kind of mat with ropes that you attach, and it's a seat. And so if you have trouble balancing, you can position yourself in the seat. Your partner could just push you like a swing and position you and move you, and you use no energy at all. And so it opens the door for near zero gravity intercourse. Try having an orgasm on a swing, fantastic stuff. And it's something when you're done, you can just unhook it and stick it under your bed. Your kids will never know. And so this is an example where I don't accept that we don't have options. We just have to create ways of making those options viable.
Yeah, and opening the door to discussing them as well too. I recall someone described intimacy as into me see. And I would often talk to people about thinking about that. Intimacy is into me see. So if you're just letting someone inside, seeing what's inside your head. And I thought it was a really lovely little description of saying, intimacy is not just touching, it's into me seeing, it's seeing that other person. And that opens the door.
I'm going to borrow that. That's fantastic. Into me.
You're very welcome to. Now, I do just want to touch on one other thing that we don't tend to talk much about in when we talk about sex, is sexual health and sexual health diseases. And I think there's probably a lot of underlying concern which a lot of gentlemen don't bring up and say, I'm worried about sexual health diseases, I'm worried about the MS treatments. Yep. What's your sort of advice on that?
This is an excellent topic, and it's too easy to ignore. Here in the United States where I practice, there's an epidemic, a resurgence of gonorrhea, chlamydia, syphilis amongst 80-year-olds in nursing homes. And there's a very, very growing large concern amongst young people, I'm talking teenagers, with gonorrhea in the United States. And so this is something that's completely preventable with a couple precautions. Now, you bring up some really important points. Contracting a sexually transmitted disease is not a great idea. Contracting a sexually transmitted disease when you're immunosuppressed is a worse of an idea. Like you're now introducing more concerns. So going back to the discussion about talking about sex, into me, see, we have to include protection. So that has to be part of the discussion. And unless the two partners both get tested and share with each other the results, then I think a barrier method is necessary. That's my opinion. Now, some people don't like condoms. Well, then go through the rigor of getting yourself tested, have your partner tested, and then look at the results. And if you're good to go, giddy up. And if you're not, wrap it up. And it's taking those precautions because it's quite a preventable thing with a couple precautions. I mean, I don't know about in Australia, but you can buy condoms for not that expensive almost anywhere in the United States.
No, very easy in Australia too.
Yeah, and I think if you are in a monogamous relationship where you're not concerned, that's a different environment. But I think particularly for people that might be dating or having more than one partner or be doing, that's very exciting. but I think that we need to just be adults and take precautions. And mind you, this has nothing to do with having MS. This has to do with being a responsible member of sexual society. But we do want to point out that sometimes the medicines that we give people for MS can suppress the immune response. And so if you have any infection, that could potentially be more of a serious thing. Hence the desire to make sure that we know what we're doing.
I think with those sexual diseases on the rise, it's a really important topic that we need to bring up more. It's something that in women, I think we're getting better at discussing it in some ways. Certainly in Australia, and maybe it's because I'm a woman, but we're better at discussing sexual diseases. But in men, I think it's in some ways, I think it's even more taboo, and we need to talk about it.
No, it is, and let's take it a step further and talk about oral sex, because sometimes adults think it's important to put on a condom if a penis goes into an orifice, but we don't have to worry about it if our mouth touches genitals, and that's actually not true. And so sometimes couples may involve themselves in fellatio or cunnilingus, and they don't use a form of protection, and that's also a risk. And so herpetic infections and all kinds of other things can be transmitted that way. And so I think that as like a public service announcement, we have to be cognizant of that. It doesn't mean that you can't engage in a 69. It just means that you need to be thinking ahead of time about ruling out sexually transmitted diseases before you do that.
I haven't seen any research that sort of strongly suggests there's a significant risk with immunosuppressive treatment. You may have, but it makes sense to think that there is.
I have not seen any data, and I think that it would be a difficult study, but I'm simply saying that when a patient who is immunosuppressed gets a upper respiratory tract infection, it has the risk of being a more severe upper respiratory tract infection. So by the same token, if a patient has an immunosuppressed state, they might not be able to fight off an infection as easily.
Another question that I'm commonly asked is the impact of MS itself and MS treatments on fertility.
Yes, great topic, very, very important. And I commonly share with people, MS does not impact your ability to become pregnant and carry a child and deliver a child. MS doesn't impact fertility directly. I joke that in Ohio, many of my patients trip and fall and they happen to become pregnant. We just don't know how. And so we want to be very, very cognizant about fertility. And as it relates to sex and life, we have to talk about planning pregnancies and protection for unplanned pregnancies when we meet the human before we put them on a medicine. So I joke when I was training fellows and residents, you say, hi, when are you going to get pregnant? Because that has to factor into our very earliest discussions. And you can say, as I pick medicines, I want to have a sense, do you have plans on starting a family in the next 5 years? So that I don't intend for that to be like me pressuring them. I'm just trying to gather information because it matters. And depending on which medicines we use, it could impact that quite a bit. And so it is very related and it needs to be top of mind. Adults like to have sex. And even if we say we're not, we may. And so I think that we have to be proactive about not allowing an unplanned pregnancy to occur, taking precautions so that everybody is safe. And as we mentioned earlier, taking other precautions for sexually transmitted disease, et cetera.
And do any of the medications, is there any time when men in particular, where it's where any of the medications are contraindicated for reproduction?
Yes. So earlier we were talking about the medicines like Viagra and Silas, and those medicines affect the vasculature. They affect blood vessels, and they can cause lightheadedness, right? And so if you have cardiovascular risk factors, then before giving those medicines, then you want to get cardiac clearance. So you don't just airy-fairy pass them out for fear that someone might have some issues with their cardiovascular system. And so that's one that comes up quite frequently. Less problems with the injection, obviously, although we tend to use that a bit less frequently. I also want to touch on another category of medicine which is very commonly used in the setting of MS and can massively impact sex, and that's managing depression. So it's very common that someone with MS will experience a bout of depression. They're twice as likely to experience depression compared to the general population. That's a lot. throw a pandemic on top of it, and I'm shocked that not everybody is on an antidepressant. And many of the antidepressants are excellent at helping depression, but the SSRI and SNRI population of medicines, which are the most common use, can create a very serious problem with erectile function or with ability to ejaculate. And if you would like to make a gentleman more depressed, remove his ability to ejaculate or to obtain an erection. Remember, I told you we love our erections. And so I think that as we start people on antidepressants, that's part of the conversation. And so when I talk about antidepressants, that's absolutely one of the things that we discuss. And I gravitate towards, routinely, I gravitate towards atypical antidepressants like bupropion, that's Wellbutrin in the United States, or Pristiq. These are medicines that are fantastic at limited sexual side effects. And so I just think as we place people on medicines, whether that be disease modification or symptomatic medicines, I want to have the bedroom top of mind.
Well, we've covered so much today, and thank you for that. I guess I think it keeps coming back to this concept of, I mean, there's so much in that, but we so need to open the discussion, keep talking about it. I know not everyone is comfortable. You obviously, you know, it's great to have a neurologist who can talk about it, but not everyone has that. So, you know, and sometimes it's the braver person. Sometimes I do encourage them to be brave and talk about it with their mates, talk about it. You never know what doors is going to open that they're going to say, oh, I've got the same thing. You know, I'm experiencing the same thing with or without MS. There's so many complications for many of us. Just normal life makes things complicated. So either GPs or local doctors, anyone that you feel comfortable with talking about it and having a bit of a knowledge base on what can be done, so that you can initiate the conversation and say, hey, but I also know that there's solutions.
You're absolutely right. And I want to bring up a resource which has really come to a head during the pandemic, and that's the power of virtual support groups. Now, as we mentioned when we started talking, men are a minority within the MS space, and support groups that are exclusively male are not common, but they exist. In fact, there's one of my favorite support groups, which is started by a nice gentleman that I know here in the United States with MS, called Men with MS, Yes, We Exist. In this support group, started just as him and his friends on Zoom, all with MS, and now there's 80, 100 some guys from around the world that get on a couple times a week. I've been privileged enough to interact with them in some of these live discussions, and it is a fantastic environment, because when you say, I'm embarrassed to talk about my erections, 80 people go, yep, me too.
Yep.
I mean, it's a culture of knowing where you don't feel like a weirdo talking about, you know, pain in your testicles or something where, you know, you would never mention that in mixed company. And so if there are, if there are opportunities like that that people can seek out, I think it's amazing. Thank you very much for tackling this topic, and thank you so much for including me. I've had a great time talking, and it's my hope that maybe someone listening to us develops a little bit of courage. We have to be self-advocates, right? Because if you have sexual dysfunction, it doesn't hurt your doctor or your nurse, not at all. It hurts you, and it hurts your family. And if you would like to ruin the quality of life of an adult, mess with the down theres, right? A great way to ruin quality of life. And that's not okay. And so I challenge people listening to this to be selfish, to be self-advocates, to say, hey, I would like to have an orgasm. Can you help me do that? And if the doctor says, what? Say, okay, well, refer me to a doctor that will.
Yeah. And there are lots of solutions. You've just raised some, but there are lots of solutions. So, like you said, it's really positive to hear. We can, and you can help. We can all help people do that. It's an achievable goal with MS. It doesn't, MS does not mean no more erections.
No, that's exactly right. I mean, I think that meaningful intercourse, just like the ability to enjoy good food and swallow, these are critically important things for the quality of our lives. And I'm just so glad that someone like yourself is trying to raise awareness, because there's something we can do about it. It's not, it shouldn't be a stigmatizing topic. It's one of the best parts of my day, week, month, depending on how lucky I may be.
Okay. Well, have a good evening, and thank you again so much. That was much appreciated, and great. Thanks so much. Here I am again, and I'd like to invite Silas to his camera on too. He's got that webcam.
How's it going? is my camera showing?
No, we can't see you yet, but while you're doing that, I will, so Silas does a lot for MS Plus, he tells me, and which he does do a lot for MS Plus. So Silas is a person living with MS, and I think just his openness and honesty and authenticity means that we do ask Silas to do a lot. This can be a particularly difficult topic of conversation for people, and so yeah. So Silas, tell us what you thought of.
Apologies, my camera's not working. I thought it was open and honest, and it's something that, you know, makes you think of the future, makes you think about, okay, this might not be my problem now, but what if it was? And then it's good to address it before you get there. So I enjoyed that part of it.
I think when we talked before, you said that you found it a little bit confronting, a little bit scary.
Yeah, totally. Like, what if that is what my MS journey looks like in the future? Yeah, that's horrifying.
Yeah, and it can be. And I guess, you know, a problem shared is a problem halved, they say, in terms of, but I think sort of coming out and saying, speaking about it to your neurologist is a really important thing to do, because sometimes there's not a, you know, it's a very high unlikelihood. Other times, yeah, this may happen. Other times it's unlikely to. So it's good to get it out there so that it's an open discussion, so that it becomes, in the future, if that becomes an issue, that is worth talking about. Now, apparently you've had an issue in the past, Silas, that you thought was a little bit awkward to talk about.
Yeah, so hi everyone, I'm going to be open and honest. I have 3 kids. I don't know how it happened, when it happened, but I had pain in my testicles, and, you know, I'm pretty active. I'll play sport, I'll pick the kids up, whatever, and I don't know if there's many dads out there can relate, but just as you pick them up, their legs are swinging, and sometimes you get kicked in the nuts. That's always fun. So I went to my doctor and I said, I don't know if this is MS or if this is normal, but I have some pain in my testicles. And yeah, then, yeah, it's an awkward conversation. He didn't know either. He's like, all right. He just referred me on. Yeah, so it's a challenging thing to talk about, and then sometimes you just avoid it.
Yeah, I think sometimes people kind of, I think men, women, or everyone actually, when it comes to talking about sex, they do tend to kind of go, or with MS, oh well, it's just part of the MS, and you know, like it's just,
Yeah.
oh well, it's just come on board. That's just something that's happened, and then to find out that it's not can be such a relief. So I guess you don't know that it's just all part of it. With women, it's menopause, you know, just plain menopause and MS for everything, without sort of going, hey, this is something we can action it, and it can be treated, which is just such an important thing. I guess it's about feeling, not all neurologists are easy to feel safe with, to bring it up. Is your neurologist, Silas, easy to discuss things with?
Yeah, he's a genius. Professor Robert Hurd is my local neurologist. Yeah, and he's great. But, you know, like, again, your relationship, your rapport with whoever you're talking to is so important. And whenever we get to those bridges, we've crossed it together, and he's been wonderful. So yeah, having good medical staff in your corner is essential.
Yeah. And look, one other place that I know is a fairly safe place to go to discuss these type of things. Again, sometimes you have to be the first person in the room to have the courage to say, I remember watching that movie, I Bought a Zoo, and
Yeah.
Matt, what's his name? The Born Identity. Anyway,
Yeah.
he said that you just need 15 seconds of courage. And sometimes it's just being the first person to say that. is the 15 seconds of courage that you need, because someone else was probably asking the same question, and that's in men's groups. And I know, Silas, you're a part of some of the MS Plus men's groups. Can you tell me a bit about how that goes in your group?
Yeah, I won't name and shame, but I get a lot out of, like, I'm thinking exactly of individuals who have opened, shown those 15 seconds of courage. Matt Damon, that's his name. And they've talked about stuff that I've learnt from, and I didn't even know it was an MS thing. So they might say of an issue that they face that week, or they have a question. I'm like, oh, like, I'm learning on the spot, thinking, oh man, like, thank you. I'm glad we're talking about it because it's going to help me. And I didn't even know. I thought it was just a me thing. So yeah, sometimes you're not sure if it's a getting older thing or a MS thing or a normal thing, and having a group of people be able to understand and speak openly goes a long way.
Yeah. Did you have anything else? I've got some questions here, so I'll ask those. Is genital numbness common for men living with MS? Oh, look, it's relatively common. Like, I was an MS nurse for 25 years, and it was certainly not something that I didn't come across quite a few times. Erectile dysfunction was probably more the common point that was discussed, but whether it was numb as well was not necessarily always discussed as well too. And it's certainly common in women as well. That genital numbness is common in women as well. So it's not rare, and it does happen, and it often comes with erectile dysfunction as well too. And as nurses in MS, I can certainly say we've got most nurses are quite comfortable talking about it, quite used to talking about it as well too. But that was certainly common enough. So if it's something that you're experiencing and you haven't really talked about it with your neurologist before, unfortunately with sensory, I mean, when the nerve goes down the spinal cord, and there's a lesion there, that's the classic symptom that sort of comes with that. With any sort of erectile dysfunction, bladder dysfunction, they can often come together because it's a blockage in the spinal cord there. And the sensory stuff is one of the harder things to treat, that's for sure. Sensory changes are definitely really challenging, and pain can also occur too. So that is rarer, much rarer. I've only had one or two people who have had really difficult pain, not so much genital, but the whole pelvic area really, or penile pain, but in that pelvic area was really painful. So that was certainly something that was just like life destroying, and another thing that can be quite difficult to treat. Next month we are going to be talking about an MS Plus. We're doing a few things about pain and sensory disturbances, so actually it's this month. So we'll be talking to a couple of pain specialists about how to manage pain, but the numbness and pain can come together, and due to the area of damage, and yes, it can be common enough. And is it safe to have children with MS is another one of the questions. So what he didn't touch on was the medications. So it's definitely safe to have children with MS. In fact, Silas is with his 3. I think it's safe, medically safe, but is it mentally safe to have 3 children ever, Silas, do you think?
It's a question dear to my heart. So I was on Aubagio, and then I went off that and went through the washout, and then conceived our second child, and then it was Jelenia and then Aubagio. I washed them both out to conceive. So is it mentally safe? Any parent would agree that it definitely has a toll, and sleep is one of the victims, definitely.
Yes. I guess those impacts can add on, but I don't think that in any way it needs to stop men having children or how many children that you have. Sometimes you just need to be a bit smarter with your resources, as all parents do. MS just seems to, I've always said about people with MS that they just up the ante on being more resourceful. in terms of having to sort of adapt to the changing needs of children. But with the medications, now they understand that Gillinera is fine to conceive on. That's when you had it earlier on. They wanted to do washouts, but Aubagio is probably the only one, and cladribine, or Mavenclad, they're the two medications that are contraindicated in male fertility. So the other ones are all okay. I mean, each neurologist has got slightly different nuances, so it's always worth having that discussion about whether they're safe or not safe to have. So sometimes they have a slightly different opinion, which is fine. That's all part of life, but it's good to have that conversation. But technically, those two are the Aubagio and Mavenclad were the two medications and Mavenclad not permanently. It was only for a duration of time around when you're taking the tablets, which you don't do all the time with the Mavenclad medication. So if you've got any questions about that, you can always call the MS Plus nurses here at MS Plus. They're a wealth of information. If you just want to come a bit prepared with your neurologist, time is of the essence, and sometimes in a neurologist appointment you want to be discussing other bits of information rather than which medication is recognised as having research for testing in sperm. And so they don't always test medications in sperm, but often they do because it's an easy one to test. So that was all the questions that I had to do that. So Silas, did you have anything else that you wanted to add? And thank you for coming on board.
Thanks for having me. Sorry about my camera. Something to add. I would like to drop a bombshell, everyone. I went and got a vasectomy, and it was the greatest thing I've ever done. It was terrible, and most of the colleagues at work are female, and they were utterly horrified that I told everyone, and I said I'm going to get it done, and then I still went out that night. It was 2 Panadol and 20 minutes, and all my female colleagues hated me. They're like, "What do you mean it was 20 minutes and 2 Panadol?" It was an injustice. They felt that it was such an easy, simple thing for a guy to go get that sorted. So I have MS. I'm on a treatment, and I've got 3 kids. I'm done having more children. I told my wonderful wife she's welcome to have more children, just not with me. And it's been nice. Yeah, so I just wanted to throw that in there. It's not relevant probably, but it's been a wonderful thing for my family.
Well, I think that's awesome that you shared that, because it means that we can, it can add so much less grief and so much less trauma to be able to do that. And infertility is another thing that people can experience as well too. So if you have any issues with that, it's definitely worth the conversation, because it's not part of MS. It's there's other reasons for that one. So make sure that you have that conversation. Well, thank you for joining us today. Thank you, Silas. We don't have your camera, but now we'll just imagine that you look like Matt Damon. So we'll run with that one. And just if you need some other services, this is where we are at MS Plus. Thank you, Annie, for all the things we offer. We've got a resource hub. This will be made available on our resource hub as well too, if you've got anyone else that you want to recommend it to. And if you want to give us a call, 1-800-042-138, we're available. And the cadets team. Thanks so much.